finding out in my own interaction with our residents, you know from the microscope it's
Good afternoon, friends. Thank you guys so much for attending the Oregon Cancer Policy Forum. Really happy to see everybody here in person. If I haven't had a chance to say hello yet, I'm Jamie Dunphy. I am the Oregon Government Relations Director for the American Cancer Society Cancer Action Network. Thank you all. I'd also like to introduce my colleague Carrie Hampton over there, who is the grassroots manager for and amazing volunteers and team folks who are here. Thank you guys all so much for being here. For those of you who don't know, American Cancer Society Cancer Action Network, ACSCAN, we're the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. We are in all 50 states and Guam and Puerto Rico. First and foremost, I'd like to thank our elected officials who are here today and their staff who have come and hung out with us. We really appreciate you guys. Senate President Rob Wagner and Mayor Joe Buck. We're going to hear from both of them in just a moment. I didn't miss anybody else, right? I didn't think so. Before we begin, I hope everybody's had a chance to get some food, a couple of programming notes. The bathrooms are just out this door to the left. Emergency exits that way. Today's event is the beginning of a longer conversation about the next generation of fight against cancer and other diseases. Our panelists today are experts in the next generation of genomic testing and diagnostics in the fight against cancer and other genetic diseases. You know, we've known for decades that the same cancer in different patients will have different results. And more, science is really helping us guide diagnostic results for individual cancers to help find the right treatment for your cancer. So by testing individual biomarkers, we'll be able to move away from some of the harshest treatments, some of the ones where the treatment is worse than the disease. And this technology isn't just for cancer. I mean, I work for the American Cancer Society Cancer Action Network. The word cancer is literally in the name twice. I'm a little obsessed, but there is a broad applicability to these things. But there's one thing I've learned in this job, is that everyone has a cancer story. I have never met somebody who doesn't have some connection to the cancer world, and all of them are horrible. And I'm really sorry for each of you guys, and I know that there's a reason you guys are in this room. Because I also know that we can end cancer in our lifetime, and it's literally going to take the people in this room all fighting towards that same direction. So thank you guys for being here, and thank you so much for dedicating your time to this. Before we begin, I want to thank our sponsors of today's event. You've seen their logos rotating up here, but without their support, we really could not do the work here in Oregon. So special thanks to Grail, Bristol Myers Squibb, Johnson & Johnson, Amgen, Genentech, Espousal Strategies, Gilead, the Oregon Nurses Association, Care Oregon, Merck, Pharma, Pfizer, Exact Sciences, OHSU's Knight Cancer Institute, and Sanofi. Yeah, that was my introduction. So it's now, before we get started, it's my pleasure to introduce the mayor of Lake Oswego, Mr. Joe Buck. Mayor Buck won his seat in November of 2020, having served previously on the Lake Oswego City Council. And you know, it's not an easy job assuming leadership in the middle of a global pandemic. So thank you for being here, and thanks for being here in person today. Mayor Joe Buck.
Thanks, Jake. Good afternoon, everyone. It's great to have you here in Lake Oswego at the Lakewood Center. Welcome to you all. I appreciate you and all of the work you do. We're thrilled to be hosting this luncheon here in Lake Oswego. Grateful to all of you for your dedication to the important work that the American Cancer Society Advocacy Arm does in fighting for greater access to healthcare, cancer prevention, and to funding critical research, and to working especially on tobacco prevention and cessation. The work that you all do is increasing the quality of life for so many of our neighbors. As we know, not everyone has equal access to healthcare or healthcare at all. Our work in city government works to improve conditions for everyone by focusing on the needs of the most disenfranchised. When we make our community accessible for people, all people, through the built environment, through housing policy, education, and programming, we improve life for every resident. And the same is true for the work you all do by focusing to ensure that those with the most limited access to medical care, preventative treatment, and the ability to make healthy life choices are centered in your advocacy. I was talking to Mackenzie earlier about, I grew up in the restaurant business. My family has a restaurant in town, in Goodbanks, where I grew up, and then I saw my friend Matt here, whose daughter worked at Goodbanks when she was in high school, and maybe 15 years before then, I was a high schooler working in Goodbanks, and back in the day, our concern was the old cigarette vending machine that we had in the back entrance, right inside the door, right next to the payphone on the wall. And the kids would come in and they would put the coins in the machine quickly and they'd get their cigarettes out of the machine. When we found out, and I said, I came home, I said, Dad, did you know that kids are coming in and buying cigarettes from that vending machine, that we have a reputation? He goes, what? Was very shocked, and so we got rid of the cigarette vending machine, and it's hard to imagine that in my lifetime, that cigarette vending machine was in the back. But now, of course, things have changed. And locally right now, we are engaging our student leaders on how to be advocates for change in their communities at all levels of government. We have youth advisors on all of our city boards, from a youth action council and a youth leadership council, and the city is investing in these multiple routes for students of varying interest to help shape the future of their city. This year, our Youth Leadership Council is working with the City Council to advocate for the passage of a much-needed statewide ban on flavored tobacco. This is the new fight. We did such a good job on traditional tobacco, eliminating it from the workplace. These changes from growing up and working in that restaurant environment, coming home as a high school busser, smelling like smoke. It just sounds ludicrous nowadays. But now we're moving on to the flavored tobacco, the vapes. These products are equally as insidious. Big tobacco and its allies have put forth this absurd narrative that the only cure for their devastatingly harmful flagship merchandise is to allow consumers to purchase another highly addictive and dangerous product. Of course, we are not buying that. Our youth aren't buying it either. And so we're counting on state intervention, partnering with our local jurisdictions and the counties to make sure that youth do not have access to these harmful products. And we really appreciate working with Jamie, who's been a great partner on this, and it's been something that our community has really been engaged on. So I'm just so glad to welcome you all here. Thank you for your advocacy. I know a lot of you are healthcare providers, volunteers, and members of families who have been touched by cancer. So thank you for all that you do. It's great to have you here.
Thank you, Mr. Mayor. It's now my honor to introduce Senate President Rob Wagner. Senator Wagner was first appointed to the Senate in early 2018. He's since gone on to win re-election back in 2022. Senator Wagner has served as Senate Majority Leader for most of his time as Senator, but this year completed his first session as Senate President. I'm thrilled he's able to join us today from his home, here in his home district, and hope he'll give us a into his thinking for the 2024 short legislative session. Please welcome Senate President Rob Wagner.
Most dangerous place for a politician is with a microphone and a screen behind me. I was told that I had 45 minutes to be able to run through. Okay. Bring the slides up. No, thank you so much for the opportunity to be here with all of you today. I thought I would share just a few remarks about both my personal history with cancer, family story, very briefly, and then talk a little bit about the legislative session. And if there's time after, I'd be glad to stick around to answer some questions. I also want to give a shout out to Maureen McGee, who is here, who is a contract lobbyist for Talk and Torp, does an incredible job for you in the Capitol. Unfortunately, she has my cell phone number, isn't afraid to use it. Also, just being here at the Lakewood Center is really special for me. I grew up in Lake Oswego, moved here. My parents are still in the same house that they bought in 1981. And I remember coming and doing actually theater here, and it's such a wonderful thing. This legislative session, we were actually able to secure $47,500 to help with Lakewood, which is great. And I know that we have a real commitment to our local art scene, so it's just wonderful getting a chance to be back in this room. I also want to give a shout out to the mayor, as I was sitting here quickly writing a couple notes. Not only is my good friend, he has an incredible record of public service here in the community. When you think about livability of Lake Oswego and our regional communities, things like fire and safety and our parks and pickleball. So, should we talk about pickleball? Also, I don't think, I've never told him this story, but when I graduated from high school, I went and I collected job applications and went around and tried to get a job at Gubex and just got the complete Heisman. Like, it's a complete stiff arm. Like, there was no way they were gonna hire me. So I ended up working at Domino's Pizza up in Mount Park. Mackenzie, that's a place where you deliver pizzas. You had to get it there within 30 minutes, otherwise it was free. And so I had this giant suburban diesel that I was driving around, and there was no GPS, and you're driving around these potted roads, just completely barreling in these neighborhoods. I mean, just middle of the night kind of stuff, throwing. I can't even imagine the condition of these horrible pizzas as I was delivering them. Also, just reflecting on the cigarette machines, and I remember quarters. Like, you remember that? Like, you would actually, people could stack up like a line of like 8 quarters in order to get a pack of cigarettes. I mean, and just in terms of, we were talking a little bit about what it is in terms of the industry that tries to get people addicted. And in terms of a personal story, my son, who's now off to Oregon State, was busted freshman year in the bathroom. This is a very, very common story that we hear because of how insidious the vape corporations are. They start with great flavor, they get our kids addicted to tobacco and going on, and then trying to break them from that habit is really, really hard. And just, I think another reason that I'm really honored to have a chance to be here is, like I said, my personal connection to cancer. My grandparents both, when Jess was saying, it's both horrible, but it's also inspiring. I had a grandfather who was diagnosed at the age of 69 with colon cancer. It was in a time that he didn't catch it early enough, and it was a very, very tough 3 to 6 months as we watched him fade away. 5 years later, my grandmother on the other side of the family, we caught colon cancer early. And she had surgery, radiation therapy, and she had a long, wonderful life, coming out of that. Also, just in terms of my own wife, her skin cancer, and just early detection and treatment, and then 2 of my colleagues. So Senate President Peter Courtney's very open about the fact that he had cancer, and then he's had really successful treatment, and it was wonderful. I mean, the care that he got at OHSU. And then our majority leader, Kate Lieber, had a cancer diagnosis in her early 40s with breast cancer, and has made an incredible recovery too. So it's been really, I want to say fun, but it's been inspiring to watch what's happened with treatment and early detection and everything that people do. And the final thing I'll say in terms of a personal story is that my dad was a cancer doc. He was born in 1946 in Southern California. He went to UCLA. It's an interesting story. He actually decided to go into medical school because at the time, it was early enough when the draft for Vietnam was up and you could get a deferment if you went into post-secondary education. And so he has a great story about trying to do dentistry, and apparently one of the requisites was that you had to do something, carving something out of chalk, and by the time he got done, it was just a pile of rubble. So working with his hands wasn't probably the best thing, but he found his way in the early days to radiation oncology. Back at UCLA, moved up here with Norm Willis, if people might remember these names, and when he started the cancer program in the basement of Providence Hospital with John Mollendijk, it was really interesting. He had a very interesting career. I remember him coming in and doing dictation and looking at slides, actual hard copy of slides of different things. And he was very quiet about what it was like to be a cancer doc in the 70s. And I think that when you think about the work that people do now, it's very, very different. And I went back through just in advance of this, because he doesn't really share too many stories. He's kind of getting up there in age now. But I found this thing from OHSU, January 8th. It was a report, and it says, Radiation Oncology in Oregon, Pioneers and Pioneering. And it was really interesting. It's like an 86-page slide, and it was really fun to see my dad actually reflected in that work. So I couldn't be prouder of the fact that of the work that he did. He always wanted to be a teacher. That was kind of his goal. And he said by the end of his career, he was so pleased that he was able to kind of bring it around full circle, because he was able to teach people about their disease and what it meant. And I think that kind of care that you see in people that work in the profession is really inspiring. Now, about the legislature, the state government, in some sense, has limited resources. I'm going to be serious. The demands that we have on our budgets are
overwhelming. When you think about what we're facing in housing and homelessness and partnering with local community nonprofits and local governments to try to address that issue. When you think about everything that we try to do around funding and matching with local school districts around education, corrections, community corrections, transportation. We just had a very long meeting thinking about 2025 and what a new transportation package is going to be. Nobody asked me about tolling, please. That's something I get asked a lot about. But at the same time, we can't ignore research and development and the important work that the state government has to do in partnership in this space. I was just texting with Connie Seeley, one of my former colleagues and good friend, trying to remind myself of what the state did in 2014 when Phil Knight made the incredible gift into the Knight Cancer Research. I think we'll probably hear a little bit about that today. I can't remember exactly what the agenda is, but with that initial $100 million and then $500 million, and then part of it was in order to achieve the $1 billion, is you had to bring private philanthropy in, and the state government at that time stepped in with $200 million of geo-bonding to be able to help develop out that program. It couldn't be, I was in the building at the time, I wasn't a legislator, but I remember the conversation. I'm really proud that Oregon met that challenge and that we're continuing to do things and trying to put resources in to partner with the great work that's happening here. Recently, just earlier this year, Senate Bill 1041 passed, which expands access to breast cancer screening by ensuring, yes, and thank you for your advocacy and your work on that, ensures diagnostic tests are covered by insurance. So obviously, maybe some applause to that. And the year before, we passed House Bill 4113, which addresses a gap in the coverage for cancer in firefighters by adding bladder and female reproductive cancers to the list of cancers that are presumed compensable by workers' comp. So, and I know you've partnered with folks in that. In 2019 and in 2021, the legislature passed bills that require health insurance to cover proton beam therapy and made it more accessible by banning prior authorizations as well. So, and what's really interesting about this is you hear a lot, I've had this job for as a Senate President for 10 months and 2 days, but who's counting? Followed somebody who was there for a few more years than me. And we went through some difficult times. We're seeing this reflected at the federal governmental level, less so in our local governments, although you see this kind of stemming up. But when you're a partisan political official, especially in today's world, there's a lot of strain and stress. And I got the chance to preside over the longest walkout in Oregon state history. Since my time in the legislature, it's been 7 walkouts over 5 years. But when we talk about things like early detection and insurance coverage and treatment and investment, these are broadly bipartisan things. I think it's really important to note that. There are still so many things we do in the state and in the federal government, especially when we're talking about the issues that we're talking about today, where people are coming together. And I think it's a testament to the work that you do in building grassroots support around these issues. We know that sometimes you're gonna run into obstacles as it relates to, we were talking about Altria and talking about the insurance companies and things like that. But the work that you do to educate legislators is so vital. And I will say that although you have wonderful representation who engage with legislators on a regular basis, you being able to come and share your personal stories are the things that make the biggest difference. Our doors are open. The legislature really is. We listen to our constituents. We're still a level of government. Although I have 141,000 constituents, when we're in legislative session, if it's a constituent, we will make every effort to make sure that we're meeting with people and hearing about their concerns, and it drives our policy-making decisions. We also have unfinished business. And I don't know if we're gonna get there in 2024, but I know that I'm committed to making sure that the flavored tobacco ban is actually implemented in the state of Oregon. I think 9 other states have done this. It's time for Oregon to join in this fight. And finally, I will say, if you have ideas and you want to share them, please engage with us. Please know that we are here to serve our communities, and like I said, it's your personal experiences and your expertise. It's what's going to drive the future of both cancer research, early detection, making sure that we're holding insurance companies accountable.
So thank you for the opportunity to be here. It's an honor, and I look forward to the conversation this afternoon too.
Well, thank you so much, Mr. Senate President. Thank you. We have a lot of work to do still in the state, but Oregon is doing some pretty amazing things. And I really appreciate you being here, so thank you. Friends, we're now on to our main event. It's my pleasure to introduce our two key speakers. Actually, Jill, would you please come up right now? Dr. Chris Cordless and Dr. Carlo Bifulca. These two gentlemen are incredibly experienced and have incredible bios, and I'm going to read these because it's important. And it might embarrass them, but I don't care. It's my pleasure to introduce the Executive Director of OHSU Knight Diagnostics Laboratory, Dr. Chris Cordless. After undergraduate study at the University of California, Berkeley, Dr. Cordless received his MD and PhD degrees from Washington University in St. Louis. He did his residency training in anatomic pathology at Brigham and Women's Hospital in Boston, where he also completed fellowship training in GI pathology and GU pathology. I obviously know what those both are. He joined the faculty at OHSU in 1994 and was promoted to professor in 2004. During his career, he served as the pathology residency program director and medical director for surgical pathology at OHSU Hospital, and for the past 12 years, he has been the director of the Knight Diagnostics Laboratory and the Knight Biolab at OHSU. An author on over 325 publications, Dr. Cordless has experience in the application of molecular diagnostics to classification and prognostication, I said that right? Of solid tumors. He's also the co-founder of a medical software company based in Beaverton. Please welcome Dr. Chris Cordless. Also with us this afternoon is Dr. Carlo Bifulca. Wow, I'm having a hard time, guys. I apologize. Dr. Bifulca is a surgical pathologist with the additional fellowship subspecialty training, expertise, and board certification in molecular genetic pathology and hematopathology. Close? Thank you. You guys are so accommodating. I appreciate you. Dr. Bifulca currently serves as Chief Medical Officer of Providence Genomics and as member and director of Translational Molecular Pathology and Molecular Genomics at the Earl A. Childs Research Institute in Portland, Oregon, which is a division of the Providence Cancer Institute. He oversees the Providence Molecular Genomics Laboratory, one of the largest clinical genomics labs in the Pacific Northwest, which provides state-of-the-art genomic sequencing to cancer patients across the 7-state PSJH system. Welcome, Dr. Bifulca. I'm going to give you guys each a couple of minutes to just correct anything that I missed. Also to just tell a little bit. I believe that everybody loves to hear about the exciting things that you work on, but also I want to know if you guys could share a little bit about how you got to this point in your career and what drove you at this point to continuing this as your main focus for your life. So, please.
So thank you for the kind introduction. It's a pleasure to join this group this afternoon. So I've been in pathology for a number of decades now. I went into pathology because I couldn't decide on any of the other disciplines in medicine. I tried them all as a student. None of them clicked with me. I went into pathology and then I realized that that is exactly where I needed to be. I was interested in the biology of the diseases that we were trying to diagnose and to treat. And so over the years, I began to focus more and more on cancer. But the tools that we had when I first started, I realize now that I started my training 35 years ago, the tools that we had were a microscope and a few special stains, things that we put on the slides to make a diagnosis. Primitive, I mean, ridiculously primitive. And looking back, I could not imagine that 35 years hence, we would be pulling DNA out of tumors, RNA out of tumors, sequencing them, figuring out what's going on at the genetic level in individual cancers, and then using that information to help inform our oncologists, radiation therapists, and surgeons about what's the next best thing for the patient in terms of treatment. I couldn't imagine it. It's been a fantastic era of progress, and I'm actually excited now to think about what the next 35 years is going to bring. Because if we came this far in just 3.5 decades, then imagine where we can be in the future. That's why when people talk about can we cure cancer, it's like, yeah, we have the technologies coming into play now that are increasingly bringing that goal into our grasp. So I have been privileged to be at the night. I've been a beneficiary of the dollars that came from the state as well as from Phil Knight and from many other donors. And the night diagnostic laboratories were formed in part because of those dollars. And that has allowed us to work at the very frontier. In other words, bring technologies into the clinical side of the laboratory as quickly as we possibly can. My one marching order from my director, who is the director of the Cancer Institute, and that's Brian Drucker. I asked him a number of years ago, what is my mission? And he said, very simply, be innovative. And I said, well, that's great. I'm not gonna worry about money, I'm not gonna worry about this, man. We're just gonna focus on trying to get the latest, greatest technologies to help our patients. And in a sense, we are a laboratory, and I'm using the word in a different sense, we are a laboratory where we can test out which new technologies are gonna be helpful and which ones may be not so helpful. And we have to go through that process in order to make sure that what we provide ultimately is beneficial to our patients, and at the same time, uses the resources that we have appropriately. So thank you again for the opportunity.
Yeah, so thank you for the invitation. I'm really honored to be here today and to have the opportunity to argue for why genomics is important in patient care. So going back to my personal history, medical school, I was actually in Milan, in Italy. And at the time, I think we were going through a pandemic. It was the HIV pandemic. Early days, people didn't know that actually people were dying from HIV, believe it or not. It was quite dramatic there. It was actually an infectious disease hospital, and we had a large population of IV drugs abusers, and young people dying with no reason. At least no reason that we could understand of. And so I had this dramatic experience of trying to understand the biology of a disease and seeing, unfortunately, the dramatic effects of not understanding it, right? Which is where we were. And that really brought me into appreciating the importance of biology in medicine, trying to understand the cause of disease, trying to understand how we can use the understanding of the cause of disease to modify the outcomes. And if you think about HIV, it has been a success story, right? Now it's a chronic disease. So I really think we can do the same with cancer. So going forward in the future, present state, I think we have incredible opportunities. We witnessed a revolution, as Chris mentioned before, in genomics. Our capacities are unprecedented in terms of what we can understand in the biology of the disease. And there's so much we can do. There's another revolution going on now, which has to do with AI, artificial intelligence. We're just seeing the tip of the iceberg. There's so much more coming. At the same time, I'm incredibly frustrated by the gap that exists between what we can do and what is done currently. I feel that gap is really what drives me every day, and what is trying to close the gap is what drives me every day. That is the reason why I'm here today. I'm trying to make an effort in closing that. I do think that the future state that HIV patients have witnessed is something that is feasible, and we are seeing the beginning of that already for many of our patients.
Well, Dr. Bifulca, while you're at the mic, what does your day-to-day look like? What is for the layman like me? What is genomics, and what do you do? I mean, am I envisioning you standing with the test tube in like a white clean room all day long, or what does that actually look like?
Yeah. So that vision is. But it's a vision that was real in some point in my past. And I think the same is true for Chris. But nowadays, I mostly sit in front of a computer, and that computer provides me information coming from genomics, provides me information coming from the patient, so electronic medical record data sets. That provides me also information coming from pathology, from the conventional microscope that Chris was mentioning before, which is still an important tool in our diagnostic workflow, so it's not something that is disappearing. But all this may give it through a computer interface. Actually, I spent a lot of time, believe it or not, writing software, directing the bioinformatics team, making sure that those components, data flows are efficient and conclusive to a better diagnostic process.
Well, Dr. Cordless, you guys might be cool in this. You guys can sit down. I think it's a small enough room, we can sort of pretend we need the microphone. But, Dr. Cordless, you've been at OHSU for 30 years. What have you seen change within OHSU, especially after the 90, Cancer Institute being built? But 30 years is a long time to get a perspective on this field. What's your experience, and why are you stuck with it for that long?
Yeah, so when my wife and I moved down here to Portland from Boston, the chair of the department where I trained was surprised to hear that I was going to Portland, Oregon, and going to Oregon Health and Science. And he said, I've been out there, it's a little bit sleepy. And so I really didn't know exactly what I was getting into when I came out. I knew that it was, not Harvard where I was being trained. So, but once I arrived, I realized a number of things. Number one, there's pathology everywhere, and I mean in the broadest sense. There's disease and cancer everywhere. Number two, there's need. Patients need our services everywhere. Number three, the opportunity to train residents, who, by the way, were just as smart and hardworking as the ones that I was around at East. So that was great. But what was really great from my standpoint in terms of spending a whole career there was the fact that the institution continued to grow and get bigger and stronger and smarter, and a lot more investment put into it, including the night dollars that we've been hearing about. And so all of that has now built, put OHSU on the map, literally as one of the premier West Coast institutions for delivering medical care and for innovative science around medicine in general, and particularly for cancer. So I've been lucky. I've been at a place that started out sleepy and is now, a terrific and world-leading place to be.
Dr. Bifulca, what is exciting for you about what's coming up in the near future? Where do you see? You said you have this long history of dealing with specifically in genomics, and you're saying a big part of your job is writing software. What are the big changes that are happening, and where do you see? What's exciting to you about what's coming down in the next decade?
Yeah, it's a combination of the two, personally, and it's a combination of the availability of very rich data sets coming from the genomic sequencing of tumors, not only of the tumors, also the germline and other pieces, and putting it together with the richness of the data which is present in the electronic medical record, which until not too long ago was completely opaque. We do pretty well in building kind of events and stuff like that. That's where the electronic medical records are really designed, unfortunately. But most of the information which is related to the patient is present in an unstructured fashion. So it's basically physician's notes, free text. And it's true for almost 90% of what you have there. AI will really transform that kind of landscape. It's all going to get structured. And it's going to be very much available and matchable with the genomic data sets. And it's just the beginning again of what I think is going to be a completely transformative change in the way we practice medicine. It's just one little niche showing you of what is potentially possible in the future. Another word I want to say is about immuno-oncology, immunotherapies. A lot of discussion today is going to be focused on targeted therapies, which are incredibly important. But immuno-oncology has also been a major player in this field. It has transformed outcomes. Diseases like melanoma, lung cancer, very difficult to cure until long ago, transformed. You probably heard of ex-presidents like Jimmy Carter, having a very home life because he actually had access to immunotherapies. Patient with melanoma, metastatic disease, and so forth could have been dead very rapidly in a different setting. So those therapies are also incredibly powerful and also driven by genomic events, which is not often appreciated. So targeted therapies and immunotherapies, come to fruition in a context driven by data, fundamentally from.
Following up on that, data is obviously going to be a big part of it. That's going to require infrastructure and systems that will work. But if patients can, it sounds like if patients are getting access to these treatments, they're seeing real results. Are we actually getting these? Are patients seeing the results of these new technological advances yet?
I spent a few days this week with a colleague of mine, not a physician but a colleague, and he was now 5 years out of a diagnosis of lung cancer, which was an advanced diagnosis at the time. We had a translocation fusion, a gene called the ALK, and if he had been diagnosed just a year before, he would have no chance to be speaking with me because the drug got approved, exactly the timeline. He had multiple recurrences with multiple genomic abnormalities driving those recurrences. Those were diagnosed. Therapy modification had been made, and he is in great shape, despite the fact that he has been living with cancer for 5 years. I feel strongly that this revolution is there and is making an impact on patients' life. Is it available to everybody in just an equal way? Not at all. I think it is distributed very unequally. I would say that this person has a high education, a great financial background, economical background, which enabled him to interact with the right physicians, being able to be critical of the process, and having a patient journey which was in part driven by himself. And that is not something that is possible for every patient, as you can imagine, unfortunately. And so I don't think we need to change that.
Dr. Cordless, what do you see as being, are there other obvious, health insurance coverage is a big one, of course, access to drug. What are some other obstacles to these sort of technologies coming into fruition and to realization in the next decade?
Actually, I think that one is the biggest.
Okay.
I'm deeply concerned about the fact that we keep getting turned down for testing that Carlo and I now regard as absolutely necessary and routine, no question about it. And so there are still some companies, we don't have to use names today, but there are still some insurance companies that are basically saying either you have to get pre-authorization, or even if you do pre-authorization, the answer is no. Now imagine this. So Carlo's laboratory runs a panel of some 500 genes on a cancer. Ours is a little smaller. Sometimes I'm a little jealous because but the fact is, we're covering hundreds of genes. Now imagine an insurance company saying, yeah, we see all those genes, and yeah, many of those are important in cancer, but those 3 are not. So we're not paying. The logic is it's mind-blowing. You can't even feature how that could be an argument, and yet it is still being made today. So right away you have a lot to care. So if Carlo's friend or my distant relative who I was talking to this week who has an ALK positive lung cancer hadn't gotten the testing done, they would have been treated with chemotherapy, it would have been 16 to 18 months, right? So, we every time we deny the opportunity for someone to get this testing done, we potentially risk losing many years of life. That's number one. The other thing that's often overlooked is that testing provides valuable negative information. Okay? People often say, well, these mutations that you can target with these drugs, they're pretty rare. There's only 1% that have this and only 3% that have that, and so it is not worth it. But wait a minute. The negative result is also important, right? There are some mutations in tumors that tell you not to use a $10,000 a month drug. Isn't it worth testing for that reason? And yet that's often overlooked. If magically everybody in every Oregonian were magically able to have these sort of biomarker testing as part of their basic health insurance, is there a capacity within our healthcare system to be able to actually effectively deliver these kind of things?
100%. The platforms are the power of the revolution that happened in genomics is I cannot overstate it. So the sequencing throughput is just enormous. And so these panels actually we're talking about with Chris are actually small things with the current generation of sequencers. So you could easily scale up to the whole population of cancer patients without any kind of major burden from a platform perspective. What I already have in-house would easily scale to the entire population of Providence cancer patients, which is 45,000 patients a year. So it's not a small joke, right? And the reality is that I cannot make it available because of the problems that Chris mentioned. It's not because I cannot scale it. It's because it is financially unsustainable currently for me to scale it up, because it would result in a burden to the patients, fundamentally, because what happens when the insurance doesn't pay, there is a process where ultimately the patient is accountable that I cannot justify. But it's not a problem of technology or scaling.
Yeah, let me just add on to that. So the NITE sponsored a special research program called Healthy Organ Project. 35 or 37 gene panel that's run on healthy adults to see if they have an inherited risk of developing cancer. BRCA1, BRCA2, and other genes that we know play a role in cancer risk were on that panel. And I recently realized that we have now sequenced 1% of all Oregonians in that project. Wasn't that constant?
Yeah, so maybe another word to give you an idea of where things are. The genome has 20x thousand genes, and to do the whole genome sequencing at the German level, it costs $300. You know, and what we're talking about here are panels which are 500 genes, right? And so a small fraction. We go deeper, so there's some technicalities here, but it gives you an idea of the fact that we could do much more, and that technology is not the bottleneck here at all.
Are there limitations to how this technology advances based on not being able to get this to enough patients? I mean, do you guys, the way I'm hearing it, sounds like the more people we test, the more our body of knowledge grows. But if you're only right now able to look at it such a small sliver, are we missing things, or are there potential advances that could happen if broader testing were available?
I'm not sure quite following. We could expand the number of genes. We could do the whole genome on everybody. I mean, that would be technically possible. But I think right now we're kind of holding back and saying we don't need that on everybody, all 20,000 genes.
Sure.
And maybe 500 is insufficient for now. But certainly we can scale with cover more patients.
Are there other diseases? I mean, right now cancer is in front of my brain all the time. But are there other diseases that naturally will, be diagnosed through biomarker testing in the future?
Well, look, think about COVID, right?
Yeah.
I remember actually being one of the first labs in the country for sequencing COVID, and people were laughing at me and saying, "Why are you sequencing this stuff?" The infectious ID docs were, very scratching their head, and now you can see how important, sequencing is for surveillance, for understanding what the new variants are going to be, to drive the vaccines and so forth. So it's fundamental, right? I mean, this stuff is fundamental biology, and I think it's going to be with us not only in cancer, but it's going to be also driving diseases like Alzheimer, Parkinson, autoimmune disorders. It's going to be all over the place. I think cancer is probably where foothold is stronger now from a clinical delivery point of view, but also thanks to pharma, who has drugs which are driven by information which comes from the genomic side. But I think we will see this applied across different diseases as well.
Are there any questions from our audience for our panelists? That was my entire list of questions.
Excuse me. As soon as I raised my hand, I'm starting to choke a little. I'm a volunteer with Making Strides Against Breast Cancer, and I do not have cancer. My mom did. And I'm not medical whatsoever, but if I understand correctly, her cancer was non-Hodgkin's lymphoma in the breast. The doctor she had was in the state of New Jersey, because we used to, unfortunately, lived in New Jersey, but we now live here. From what I understand, normally non-Hodgkin's is located other places, but not generally in the breast. When we were in New Jersey and she was going through her treatment, the research that the doctor was trying to do didn't really go anywhere. And 12-ish years later, we still can't get that information. And I think she's gonna correct me if I'm wrong, because we're that type of people, we have big mouths. that when she went in for her last mammogram, I think it has to do with insurance companies and how the radiologist codes it. Depends on if the insurance company is going to pay for it. She has a history of mainly liquid-filled cysts in her breast that the surgeon was able to go in, suck that stuff out. She's had one lumpectomy. The cancerous one had shown that it was supposed to be liquid-filled. They went to go try and drain it. Nothing came out. The biopsy was that it was non-Hodgkin's lymphoma in the breast. My question is, what the hell? Basically,
I guess my concern is what do I need to be on the lookout for, not only for myself, but I have 3 daughters and I have 2 granddaughters. Is this something that they need to be tested for, checked for, biomarker, whatever? Any input that we could get would be much appreciated, because Mika here says she has a friend that had the same thing. The treatment was different than mine in our brief conversation. But I'm curious, what is my future? It was 12 years ago. And like I said, what do my daughters and granddaughters need to be on the lookout for?
So, well, first of all, it's very fortunate that they made the correct diagnosis and treated it well. And
Yeah.
You're doing well 12 years later. That's
Yes,
that's
yes.
fantastic. And Carl and I think we both agree we're not aware of any genetic predispositions for non-Hodgkin's lymphoma that would necessarily suggest that you should get tested right now. If you had traditional breast cancer, the answer would be yes, right? But with NHL, we don't really have anything right now that we can point to. Need more research.
Thank you for sharing.
These technologies you guys are describing are wonderful. Do you, in your opinion, think that everyone has equivalent access to these technologies, or is it primarily more affluent, more educated, more urban citizens? Are the technologies being spread widely across different populations?
I think there's 2 sides to that. One is, can you get access from remote areas of the country? And the answer is yes. You can send material from almost anywhere and get testing done either at an academic or a commercial laboratory. I think the bigger question is, what kind of insurance do you have? And that's going to vary both in terms of geography, but also in terms of what kind of work you're doing and other access issues as well.
Yeah, and what I want to layer on top of that, one of the issues is also what kind of oncologist you have. Because ultimately the oncologist will act as an advocate on your behalf. And if you healthy, affluent, you live in an urban environment, you will have an oncologist which is likely to have a high level of expertise, a good understanding of the therapeutic options, and familiarity with genomic testing. While if you're in a rural area, you're poor, socially unprivileged, and so forth, your chances of having an oncologist which matches all those criteria are much lower. So the end result, I think, is that there are gigantic, huge injustices and inequalities in the distribution and access to these kind of therapies because of what you just described.
Piggybacking off of that, what kind of resources are available for language barriers for folks from other diverse backgrounds?
I mean, I can tell you a little bit what we are trying to do. We're trying to build interfaces which are patient-facing. We did that in some of our genomic programs. We have a program where we actually enrolled folks for whole genome sequencing as a tool for identifying cancer predisposition and pharmacogenomics. And we would have interfaces which are addressing folks who speak Spanish, and not only English speaking. I do think that usually it is around Spanish as a second language or first language, and it doesn't go much broader than that. So I suspect we could do better than that. I do know that we're trying to build interfaces in the cancer setting as well, which face the patient population to inform them about the whole process, because there's a journey for people who are diagnosed with cancer. this is it's first of all a dramatic, emotional experience. But also, I do think the timelines are very frustrating. Before people actually get to the definitive diagnosis and know what is actionable, it often takes weeks, if not months. And so having something which relates to the patient during the process and tries to explain them what they're going through and what the options are and what sources of information are going to be provided with is very important. And so we're trying to build a direct connection actually from the genomics program to the patients. Obviously, in the context of care delivered by the oncologist, where we're trying to facilitate that kind of communication. I do think that that is usually not well done. So this is, I think we are somehow at the cutting edge. We're trying to do this kind of process. Unfortunately, I wish we were in a different position.
Any other questions? All right. Well, I want to thank. Oh, yeah. Please.
I think we're here today because we strongly believe in genetic testing for especially all of our patients who will deserve the care that they need. My question to you is, what would be your recommendation in moving this forward so that the Oregonians here can have access and have free genetic testing? Are there other states that you've noticed that have already went through that next step and are seeing that level of access that we're already touching upon? And what can we do here in our state to make that next step forward?
Yeah, it's an interesting question. There have been some major programs put forward. For example, the Geisinger Center healthcare program in Pennsylvania secured third-party funding that then ended up paying for a lot of sequencing on a significant chunk of the population. I think Kaiser's had similar initiatives, and there are other groups around the country that are trying to do it. It's not so much state-based, but it's more system-based. And your group is trying to expand quite a bit across all the provinces.
Yeah, we did a big effort in that sense. So I think that's one pathway. The other pathway has to do, I guess, with the commercial insurance providers. So pre-authorization processes can be a tool they use to restrict access. So legislation trying to address that can be very helpful. I think some states have been enacted legislation in that sense. And the same also is true with the reimbursement that Chris was mentioning before. Having them dig in and say, because in the list of 500 genes there is one they don't like for whatever reason is absurd. So having some kind of legislative mechanism which makes that impossible from my perspective would also be a game changer. From care delivery. So thank you for the question because it makes it really practical so those are steps that I feel could shift delivery of care to our patients in the future.
And so,
So 2024,
Yeah.
2025.
No pressure.
The contract lobbyists over here with very busy hands writing down the idea for a bill concept.
well,
So
I will preview just to piggyback on that. Biomarker testing, getting biomarker testing coverage for patients across all types of insurance has been a priority for ACSCAN for the last few years. We have successfully passed legislation in 11 states, I believe, as of right now, and we have campaigns running in another, something like that. It is a nationwide priority for us to try and get this next generation of technology accessible to all patients. And I will play my cards right now and just let you know that in 2025, it will be our top legislative priority in the long legislative session. The short legislative session, I don't think we should, that's a little, I don't want to torture our friends. 2024, we're going to try and get our unfinished work finished around flavored tobacco, but 2025, we will be having some broader conversations, and I really hope that every person in this room will be ready to engage and help us to make that next step, because I can't do it alone, and we can't do it alone. So, Dr. Cordless, Dr. Bifulca, thank you guys both so very much for being here, and also thank you for dedicating your careers to this work. This is meaningful work that is changing lives. Thank you both. Make sure you guys get so much food, and thank you guys. So this is the end of our formal program. Thank you guys all so much for being here. I really hope everybody got some food. Just you know, to be very clear, this is my one fundraiser a year. I thank you to all the sponsors who helped make this event happen. That work goes directly to supporting our efforts here in the state. If you are able and willing to donate as well, this leads to a donation link that goes, money goes directly to funding our efforts on advocacy. So thank you guys all so much for being here. Thank you, Lake Oswego Mayor Joe Buck, Senate President Rob Wagner. Thank you all so much, and please take home some leftovers. Thank you guys. Thank you all.
Have the rest of the day.
Here.